Good morning, ladies and gentlemen. It's really a great pleasure to be here today. A great pleasure to be part of this event. Thank you to the PCDH19 Alliance for organizing those meetings, and thank you to the families and all the collaborations that we have, and the collaborations that were so close that we tried to say something new in PCDH19 disease, in PCDH19 epilepsy. So, my talk is mainly a clinical talk. Obviously, I'm a clinician, and I will mainly talk about what we know since now about PCDH19 epilepsy. Some very brief access to the history, the historical perspective, the clinical findings. I will show you the seizure semiology and some type of seizure that are very common in this disease. And what I would like to add as a new findings, the affected males that are really a new thing, that two papers have been published very recently, one paper a month ago and the other one a couple of months ago, and some clues on the differential diagnosis, mainly with the Dravet syndrome, because we don't want to have more and we don't want to hear more from clinicians that this is a variant of Dravet syndrome, but this is a completely different condition. And by chance it was discovered in negative Dravet syndrome patients. So it's a completely different condition, and it should be recognized as it is. And then I will try to show you some clues about the classification. Okay, let's move in 1971, when it was firstly reported that 15 females were affected by some kind of convulsive disorder, in which you had only that only affected females with convulsive disorder and with mental retardation. Obviously, in 1971, it was a clinical description. Anyone was aware about the PCDH19. The things were there for several years, but no more papers came out for the next at least 20-30 years. What is now very well recognized that in epileptic encephalopathies and also in other epileptic conditions that are for genetic origin is that a gene is the cause of the condition. And you can see here that PCDH19 is something that was came out between 2009 and 2010. This is a very nice paper that was early view yesterday on epilepsy. And you can see here that there are lots of other genes, so it's complicated to understand and to classify and to find the etiology of several kind of epileptic conditions. And so it's really a big mess when we are talking about genetic and epilepsy. So what we know since now about PCDH19, we know that we have children that starts with an epileptic condition between 3 months and 3.5 years. We know that it is restricted to females, at least since a couple months ago. And we know that most of the cases present a febrile condition before a viral infection, sometimes sometimes gastroenteritis, sometimes very mild fever condition, and so that is classical to be as a presentation symptom. We know that the seizures are repetitive, sometimes with status epilepticus. The seizures are every other times focal. We don't have generalized seizure in this condition. We have only focal seizure. If you look at the seizure, if you look at the EEGs, and if you look at very accurately the semiology of seizure, they are focal seizure. They are not generalized seizure. interictal and ictal EEG. Interictal EEG is not very well informative, so it's a characteristic of this condition. And ictal EEG might be diffuse with some kinds of involvement on the frontal and temporal areas of the both hemisphere. MRI is always normal, at least since now, but we are looking at the MRIs of those patients at the light also of some findings, and maybe we will discuss later during the day. About the treatment, the clusters are surely beta-glutamine are the most effective drugs, and drug resistance during the follow-up is quite frequent. Even if you might have some very prolonged seizure-free period that we will see if they are related or not to the treatment, but we don't have so many data. So these are the publications that I tried to find out from 2008 to 2016. We will go back on this slide later just to show you that there are maybe, I'm sorry if I missed something, but I don't think, but anyway, these are all clinical cases, and you know that it's not so many, papers on that. So it's still something that is under revision. It's still something that is under study. Let's move to the first paper, 2008, Nature Genetics, in which have been reported that the mutation was associated with mental retardation and limited to females, and they found a mutation in some patients with EFMR. Most of the cases were familiar, and it is something that is very, how can I say, similar to what was reported in 1971. So, but now we have the gene, so the condition was genetically determined. And if you look at this nice paper published on Neurology 209, the indication to perform the genetic analysis in those patients was having this condition, epilepsy, in the first years of life, only in females, but you see here that mental retardation and psychiatric features should have been one of the main features in order to ask the geneticists to try to find the mutation. So what we need now, we need to perform the diagnosis very soon because obviously the pressure, as was saying Joe, is very high on the families, and we need to identify the syndrome. And in order to identify the syndrome, we need to have those tools, those age at onset, presentation, seizure semiology. So we need to know how the phenotype, the global phenotype of the condition and of the patient, and obviously which are the advantages. Useless investigations, sometimes there are. Now it's quite easy to do the diagnosis, but think about the patients that now are 30-35 years. They had mainly 3 to 4 MRIs, they had 2 to 3 to 4 lumbar punctures, and so very lots of investigation that were absolutely unuseful. So what we need collaborative population studies. We need very big numbers in order to understand. And why? Because we need to analyze the clinical and EEG features. We need to find prognostic factors that might give us some insights in order to predict the outcome and the moment of diagnosis. I would like to say to the families, the day that I say your daughter has a PCDH19 mutation, I would like to say it will go in a good way, it will go bad, it will go so and so, but we need to know very early. And I think that we can do it if we look at all the patients, if we classify, if we put together the phenotypes. So we have lots of work to do, and also this is thanks to the genotype-phenotype correlation. Also, the other problem is the treatment. We don't have any issues about the treatment. We don't have any other indications. We have some data about the treatment, but we don't know which is the drug that is more effective rather than the other one, and obviously the outcome. We tried to start with these collaborative studies. This is only an Italian one, and we are trying to do something more wider in the future. We look at the story and the phenotype of 51 patients, and we try to look at those items, so type of mutation, age at onset, seizure semiology, treatment, and so on. We did a report. We have a report form to be filled, and also we look at the EEG of the patient. We look at 470 EEGs in order to understand if there is a common features when you look at the EEGs, if there is a common EEG pattern, interictal and ictal. Let's see the results. And the results are divided in clinical results, EEG results, treatment, and maybe I will skip genetic results. So if you look at the age at onset in 51 patients, you see that the peak is around the first years of life, with some patients also having the onset after, oh my god, after the second year of life, after the second year of life, and this is the age at last observation. So we have a very prolonged follow-up in those patients. What about the seizure semiology? Seizure semiology, as I told you, seizures are focal in all patients, and the most frequent type of seizure maybe is, we defined it hypomotor. It means that the child is doing nothing during the seizure, is only lying there looking and with a stare and doing other things, maybe having some vegetative symptoms, but we will show you, I will show you. Another type of seizure we classified is motor, and is in the about 50% of them. So motor seizure are seizures in which you have an involvement of with the movement, and you might have some hypertonus, some tremor, but you never, and very rarely, you have really clonic jerks, as this is a differentiation with other epilepsies. And affective symptoms are also very well present. The fear, there are some papers talking about the fear. The seizure characterized by fear is something that is very common in those patients. And you have also apparently generalized seizure, but we call it apparently because if you look at very well the EEG, they are not generalized, but they are focal seizure. Okay, regarding the frequency, I would like to show you 3 examples, because we were also yesterday talking about the drugs, which is the best drugs, and I had a new drug and I stayed 2 years without seizure. But if you look at the frequency of seizure, it's very, very strange. I mean, you might have some periods with full of seizure, then you might have remission, again 2 years remission, and again seizure. Apparently without any reason. Look at this other scheme. 22 years old, this patient, and she had a seizure in the first part, and then a break, and then again another break, again, I will not use this one. Again, okay. Can you see here? Okay. Again, you have another period in which you have a very prolonged seizure-free period, but later again cluster of seizure and a new period, the seizure-free period. So it's very, very, and these are only a couple of examples, but we can, all of us that follow patients can, and also parents can report that there might be some seizure-free period that sometimes are maybe falsely falsely associated to the treatment. But what we think is that is a natural evolution, is a natural history of the disease. So the epilepsy might have some good and bad periods, maybe independently from the treatment. We don't know right now. And I would like to show this type of seizure that is very common. This is a fear seizure. She's saying, I have fear, I'm fear. And then she has this kind of high deviation and a staring. But everything started with a fear, with an intense fear. So this is a quite common seizure type in those patients. Okay, let's move to the other commonest type of seizure, that is the hypomotor one, and look here in two different patients. How can seizure be similar? You see here on the both sides, the patient has just a brief hypertonus, very brief hypertonus also here, and then doing nothing, just a deviation of the eyes, and they are like catatonic. Look at here and here again, absolutely doing nothing, looking, maybe with some brief alteration. Seizures might be quite prolonged, the hypomotor seizure. I mean 2, 3, 4 minutes. And sometimes they require oxygen because you might have breathing difficulties. But you can see here, absolutely hypomotor. So let's move to the ictal EEG. And what I would like to point out to you that ictal EEG showed a clear focal discharge in the 60% of patients, but a discharge that we classified as apparently generalized, and I will show you some examples in 40% and 37% of patients. Where is the commonest region? Where is the commonest region where the discharge starts? It's the temporal area, right or left, with some involvement of frontal also. But really, most of the seizures starts from the bilateral temporal regions. And you can see here that also regarding the ictal EEG, we had the chance to record the status in 13% of patients, so it's something that is quite well present in those patients. And sleep is a moment that is very, it's a facilitating factor inducing seizures. And if you look at the seizure, you can see here what we call focal. You have the discharge here very nicely on the T46 channels, so it's a temporal lobe seizure. And this is what we call the apparently generalized pattern, but you might have some fast rhythm preceding over the frontal region. So maybe this is a frontal seizure with fast bilateralization. So both of them are focal. And this is again a wider picture of the temporal lobe seizure that is here. And also you might have another type of the apparently generalized. This is the ictal pattern of the seizure, of the hypomotor seizure. So the ictal pattern. Someone is pushing. I'm not touching. Okay. This is the ictal pattern of the hypermotor seizure. You can see here that you have a diffuse desynchronization of the activity, and then slow waves intermingled with some spikes. Okay. With spiking wave and desaturation also. Okay. This is another pattern, EEG pattern, and you can see here. And you can see here that it's very similar to the previous one, but the difference here is that on the muscle channel you have the hypertonus. So EEG similar, but different type of seizure. The previous one was hypermotor. This one is tonic vibratory seizure. It's much more involving the muscle. It's a motor seizure. Regarding the interictal EEG, you can see here again that the abnormalities, both slow abnormalities and epileptiform abnormalities, are focal and mainly temporal. Let's move to the treatment. Regarding the treatment in those 50 patients, you see that most of the patients had here. Most of the patients had 2 and 3 antiepileptic medications. Few of them 1 antiepileptic medication, and you can see here that most of them, 66%, had between 3 and 9 antiepileptic medication in the previous history. So it's a lot of drugs, and despite those medications, seizure frequency in most of the patients is not modified and is not changed. Which are the more frequent drugs used? Obviously, valproic acid. You have also carbamazepine as a second choice, phenobarb as a second choice, and carbamazepine as a third choice drug. So this is a paper that was recently published and confirmed what we found in our cases. Here you have the most frequently drugs used are clobazam, levetiracetam, phenobarb, valproate, and some of them topiramate. But really, a strong association between one drug and a good and dramatic reduction of seizure frequency has not been pointed out. We want to point out that also some of patients are now taking stiripentol, and it might be useful, but again, you can see the story from one side or you can see the story from the other side. And in order to have this nice publication, we saw the story from this side. Okay. In the 2011, these are the clusters of seizure. We put the patient on stiripentol and no more cluster. So, but again, we can say that this might be a natural story of the disease. We don't know. We need more patients to understand. So, let's move to the cognitive delay and the behavioral disturbances. You see here that one third of patients might have normal to borderline cognitive level, and 62% of patients might, so about three-fourths, have mild to moderate to severe mental retardation. But you can see here that the patients with severe mental retardation, fortunately, are quite few. So about 10% of all the patients reported. And regarding the behavioral comorbidities and behavioral disturbances, you can see here that only 50% might present some behavioral disturbances in these patients. Looking here again, which are the association between the cognitive and the behavioral disorder? You can see here that you can see here that you have, if you have a very early onset of the disease here, there is a much wider association with cognitive delay. This is the onset later, and it's less present, the cognitive delay. And again, the behavioral, sorry for the language, the behavioral disturbances, if you have an onset of the epilepsy very early, you might have more frequently the association with behavioral disturbances. So that's one important thing that we can, that we know, and that we can say to parents. If your child, if the seizure starts in the first months of life, the chance to have a cognitive delay or behavioral disturbances is unfortunately higher. And this is also something that we look at very carefully in 11 of our patients, and you can see here in the follow-up from the onset, the follow-up first year, second year, you have here the these are 4 patients, and you have here the curves of abilities, and you see that the general quotient is almost there, and you can see that what is going down most frequently is language, and sometimes you have problem in eye and hand coordinations, and also you have much better responses if you look at the social and personal abilities. So this is something that should be better studies in with higher cohort of patients. And looking at the overall clinical outcome, you have here that, again, looking at age at onset, the patients that have an onset very early might have the persistence of seizures during their life. And the patients that have an onset later has less probability. This is disactivated, this here. So I don't know why it's moving, I don't know why. Okay, and the patient that has a later onset might have a less probability, or more probability to have 2 years without seizures. Okay, let's move to the new, 2 new things I would like to say in the last part of the presentation. We have now males, finally, but we were sure since few years that white males could not have the same conditions. Why not? We have some males with a very similar phenotype, and we were trying to understand why we didn't find any mutation. They are obviously mosaic males, but if you look at the clinical features of the 2 male patients in this paper, the male patient that was reported in 2009 and the female patients, they are very, very similar. Fever sensitivity is present in all the cases. Cluster occurrence is present in all the cases. Seizures are quite similar, and I will show you an example of a seizure. And icteric EEG is, you have here right frontocentral spikes, bilateral slow waves, rare focal epileptiform abnormality, so not very different. And also behavioral disturbances is very similar to the female patients. And also drug resistant is quite similar in between. So I want to show you the story of this guy, 3 years and a half boy, the only child, normal child, epilepsy onset at the age of 10 months, with 24 hours febrile cluster of seizures that were characterized by fixed gaits, loss of contact, and hypertonia. Interictal EEG was normal. And he was started on the treatment, phenobarb, at the age of 15 months. A second cluster of seizure occurred. It was added valproic acid. And fever sensitivity was very, very high. And therefore, the first hypothesis was Dravet syndrome. Why? Because before this child, we didn't have any other child with the PCDH19 mutation. And maybe now, if you have this kind of child, you go directly to PCDH19. Anyway, SCN1A mutation was negative, and he continued to present a cluster of febrile or afebrile seizures. And with neuropsychological evaluation, it was quite normal at 30 months. He has a mutation, obviously, and look here on the left, seizure of this boy. And look here, a seizure of a girl. Very, very similar seizure. Both of them tonic vibratory seizure. Both of them with some focal sign inside. So really you have here a common pattern and a common pathway of the seizure in the brain. Maybe the brain is, maybe the seizure is doing a very similar way in the cortex. And this is the seizure of the patient, of the male patient, and this is the seizure of the female patient. Also the EEG pattern is quite similar. This is the result of the genetic mutation, and the patient was a mosaic, and we had the chance to find on the hair and the saliva the mutation. Okay, this is another guy that was reported very recently with a mosaic mutation for a truncating variant, and again the author says that the phenotype is very similar to what has been already reported in the female patients. Okay, let's move to the differential diagnosis. I just want to put you on few slides on the differential diagnosis with Dravet syndrome. Why? I told you before, because there are so many publications in which you can say we found PCDH19 mutation in Dravet syndrome negative patients. So they are not Dravet syndrome negative patients; they are different patients. Other possibilities are encephalitis and pharynx, but we will not discuss about this. Only to see that 201 was one of the first description of the S1A mutation in Dravet syndrome. 208 was the first description of PCDH19 patients, and why maybe there is this kind of overlapping in the future years since 208. I'll show you now because there are some similarities should be acknowledged. I will show you, but really 2012 plus published again a nice paper with identification of SCN1A and PCDH19 mutation in children with Dravet syndrome, and they stated that they stated that 3 out of 18 patients were negative. The mutation SCN1A was negative, and they were affected, and they were PCDH19 carriers mutation. So all Dravet syndrome patients with 2 different genes. That is something that I believe, and maybe most of the clinicians here might agree with me. Why there might be this kind of overlap at the onset? Because all of them has a normal development before, because the age is quite similar, even if we will see some difference, and because you have the febrile susceptibility. All of in the two conditions you have the febrile susceptibility, and that's why you have this kind of overlap that should be clarified. So we look at the differences in our cases: 50 patients with PCDH19 related epilepsy and 19 with Dravet syndrome, and we excluded patients with SCN1A mutation without the clinical diagnosis of Dravet syndrome. And if you look at the results, okay, This is very complicated with several numbers, but I will show you the box plot. You see here that if you look at the age at onset, we have that Dravet syndrome patients have an onset very early if compared with PCDH19 mutation. And maybe Joe, you're doing something in order to keep me faster. And if you look at the seizure occurrence and duration in Dravet syndrome and PCDH19 related epilepsy, you see that in Dravet syndrome, clustered seizures are much less prominent rather than in PCDH19. And prolonged seizure, instead, on the other side, are something that are mainly a characteristic and feature of Dravet syndrome. And also, if you look at the IQ by mutation, you see that PCDH19 patient has a wider range of IQ score. So it means that the phenotypes and the spectrum is wider if you look at the IQ. We might have normal patients, we might have severely affected patients, but in Dravet syndrome, all the patients are much more affected if you look at the IQ. And also the seizure semiology is very nicely different. Myoclonic and tonic-clonic generalized seizure are mainly an hallmark of Dravet syndrome, and focal motor seizure and hypomotor seizure are an hallmark of PCDH19 mutation patient. And if you look here also, we saw the seizure. I just want to show that the seizure might falsely seem similar. You have you saw already this seizure. Okay, and this is a tonic vibratory seizure on your right. And that is a tonic-clonic seizure in SCN1A patient. You can have more vibration, more vibratory here, more jerks over there. So if you look at the description by parents, they might be very similar seizure, but if you record the seizure, if you look at the EEG, and if you look at the semiology, you can find some difference. Look at the Dravet syndrome patient doing jerks, myoclonic jerks, and this patient doing only a vibration. So you can really differentiate them if you study it. This is the summary of the differences between Dravet and PCDH19. We talked about the age at onset, we talked about the seizure semiology, where hypomotor and seizure with affective symptoms are much more present in PCDH19 seizure, and also prolonged seizure on the other side are an hallmark of Dravet syndrome patients. Okay, let's go to the conclusion in the last 3 minutes of this presentation. First conclusion is that epilepsy associated with PCDH19 is not a variant of Dravet syndrome, so we would like to point out this. And also I would like to point out that the devil, oh my god, the devil is in the details, and we don't leave the diagnosis to the NGS panel. Look at the phenotype. We have to study the patient. We have to record the seizure. We have to look at the seizure, because if you go on the NGS panel, we will have some responses, but we cannot put on the clinical part. So start from the phenotype and go to the genotype. I want to acknowledge this picture that was taken a couple of years ago at UCSF when we started to discuss about the name. So female infant onset cluster epilepsy, female only epilepsy cluster seizure, female only cluster seizure again, infantile cluster. So several names have been proposed by Ingrid Scheffer, and also there was a nice table where all of us were putting notes, and but really we didn't came out to a conclusion. If we go back on the slides on almost all the papers, we see that clusters are really present in all patients, all of them. And fever is present in almost 100% of patients. So what is a possibility of the name? We have the fever, we have the seizure in clusters, we have now male and also we have female but also male. So why we have to restrict all those PCDH19 to female? The onset is on infancy, and seizures are focal in 100% of the patients. So I tried to find a name, but it's really difficult. One possibility to be discussed might be fever-induced clustered epilepsy. So something that is clustered epilepsy, because we saw that 100% of patients have seizure in clusters, and almost 100% of patients at the beginning have seizures that are induced by fever. So don't considering female and male, and don't considering also the onset in infancy. So the spectrum of patients we discussed, the stormy onset that I like very much, as you pointed out, Joe, because the onset is stormy in those patients and often related to febrile episode. The cluster tend to recur during the life, and the severity does not correlate to the development and degree of cognitive deficit. The molecular diagnosis is important, and the treatment strategies, unfortunately, since now are lacking. We are trying to find a treatment strategy. And the main recurrence is to be clarified in order to I don't know why there is only 3 patients, maybe more patients should be diagnosed. And obviously the need of the name. I would like to close with this slide, with this picture that was taken in October 2015 in Rome, and you have here Joe, Albina Petroneva, you have here Joseph, you have Jack Parent, you have Legan from France, Igurashi from Japan, and also Alessandra Terracciano, and family association, Francesca Squillante, and Manella, and all the other family. There's me, Marina, my boss Federico Vigevano, and my wife also. And I thank you for your kind attention. These are our main collaborations now around the world, and these are the collaboration in our hospital. And I would like also to thank PCDH19 Insieme per la Ricerca Onlus for the help and for the support. Thank you so much for your attention.
So we have time. Whoa, sorry. So we have time for a couple quick questions while we get the next speaker ready. Does anybody have a question? Question in the back. 1 sec.
The study that you showed, the identification of SCN1A and PCDH19 mutations in the Chinese children with Dravet syndrome, do you know if any of those children had both mutations, or were some of them SCN1A and some PCDH19?
As far as I know, our patients, any other of our patients has both. Are you talking about having both mutations?
Right.
No, in our patient. I don't know if they are reported in literature. I don't think so, but maybe I missed something. You know something, Anne? No? Marina, you know some? No, I don't think so. They're not, at least not reported patients with both the mutations.
Okay, because my daughter has both, and she's technically been diagnosed with Dravet syndrome, but she's got symptoms of both, so I was just curious if there were any studies reported. Thank you.
Sorry.
Go ahead, Joseph. That's very interesting to have both SCN1A and PCDH19. Would be kind of interesting to look at what type of variants they have, because SCN1A is very frequently mutated. Also, by genome-wide association study, it has been found to have variation which will be predisposing or modifying seizures.
So variation in SCN1A can perhaps be more severe, but still relevant. So probably it might be important to look, in addition to PCDH19, maybe to SCN1A variation in some of these disorders, if that can explain the variation.
Yes, and also, thank you, Joe. And also, I would like to point out that what I told it before, we have to take NGS panel on a side and look at the phenotype. So this is one of the case in which our job is very important in order to tell you which is the phenotype of your child and which is the condition.
I have one other question. Nicola, this was fantastic, and we really learn every time, and you have probably the largest number of cases, so very well positioned. What is my question about is that initially when we found this, we found it on families, where there were old, mature women, they looked after the families. It almost looked like it was a different disorder. Now, and mostly here in the room, are probably represented parents of small children. Now, did you have a chance to look through these families? I mean, not probably all of these mutations are de novo. There are probably mothers and grandmothers in these pedigrees. It's really curious I'm really curious to know what happens to these girls later in their life. Of course, we knew the gene for about 8 years, so those diagnosed 8 years ago are probably going to be about puberty. But there must be 20, 30, 40, 50, 60-year-old women with PCDH19. How do they look in comparison to these kids? I would like to know, if you can comment on
Sure. We have some patients. We have at least, as far as I remember, a patient that has 42, 43 years, a couple of patients 35 years. It depends. They are what they were when they were a child. I mean, I would like to say that if they are cognitive normal or borderline when they have 10, 15, they will be the same all over their life. And if they are normal, they will be normal all over their life. I have a patient that is absolutely normal, and she's doing a university without seizure. And also another point is the recurrence of the mutations. How many of them have been inherited the mutation? I believe that lots of the patients. I don't know exactly. Do you know, Marina, how many of those patients have inherited the mutation from mothers, from unaffected, so-called unaffected mothers? Do you know? Maybe, I think, at least 20-25% they have inherited the mutation from the so-called unaffected mothers. Yes. Yeah.
Very interesting.
And one final question, Paul.
Thank you. Thanks. Great talk. Really great clinical overview. You mentioned at the start, you hinted this, perhaps MRI data that was interesting. Could you expand a little bit on that for us?
I don't have right now MRI data. I would like to look at the MRI, but there is a paper, nice paper that was, I think it came out 1 week ago. The paper, yes, there's a paper. The one that we were looking yesterday, Marina, on the migration disorder. Yeah. So there is something there. Sorry. Maybe it's your paper.
We have a mouse paper, but no human MRI data in our paper.
Not human MRI, yes. There is no human MRI data. What also was published by Alessandro Terracciano, our group, is that the mutation, but I think that other people might explain better than me, might affect the migration of the neurons. So we have to go back on the MRIs and look at the MRIs very carefully. Maybe we will find something, yeah. But there is no data about the human MRIs.
Great, thank you, Nicola.
Thank you.
We're going to see if it's only you that's cursed with the computer next. So